tech support. There we go. As Chris mentioned, so currently heading up primary care and investments at Amplar Health, which is a division of Medibank. Primary care really is around the GP side of the business, which is a growing element of the health story within Amplar, which I'll talk about in a moment. But I just really wanted to talk about how the... I don't think this is working, guys, so I might just have to keep clicking. Follow me. Next slide. Yeah, thanks. What I really want to talk today about is really around how the convergence of health and ageing is really coming together, and how the innovations in both sectors are starting to play out and show up and manifest in different parts. We heard a lot about macro trends the last couple of days, seen lots of little graphs. These ones are colourful with no data, so I just want to point that out. It's a little bit different, but I think we've all heard this before, and about the different things that are happening around the sector. I think what's most stark is really around the demand, supply, and the productivity challenges, coupled with a seismic shift in regulation changes over the last little while, which is driving new thinking and new ways of working. I think what's also sort of coming through the pipeline is what's happening elsewhere in the healthcare sector, and particularly the technology changes that have been driven top down through innovation across AI and other platforms is really starting to impact not just the health system, but will come across wider throughout the ageing process as well. So, there we go, it's amazing. So we did talk about a lot of seismic shifts yesterday, and how much of the supply side is really driving a lot of the conversation yesterday. I think we all know the numbers. There were quite a range of different numbers shown yesterday. Now, particularly in the home care sector one, I was actually debating whether I include the CHSB numbers in the slide or not. And I was really actually pleased to see that they were in people's slides yesterday, because they haven't been really showing up in many presentations over the last few years. But that impending convergence of the CHSB with the home care package program, which has been mooted for about 10 years, looks like it might actually eventually happen. But that is going to cause another seismic shift in the way everything works, because it's a fundamentally different operating model running CHSB than HCP at that lower level model. So on what we haven't discussed much yesterday was just the absolute trauma that the industry's gone through post-COVID around building and supply of built form. The amount of construction costs that were so high, the planning issues, the ability to get funding, it was really it caused quite a slowdown in the supply of built form over the last few years, and really hard to trickle through. So when you see some of these numbers around how many built form we want to get to and what the supply on demand can absorb, we have to remember that it was really, last few years, everything really slowed down quite significantly. And it's only just started to come out now. We heard from the CBA guy yesterday saying that he's only now starting to see feasibilities start to stack up. So, we're sort of catching up, not just from what demand is today, but also the slowdown in the last few years as well. I think the other thing that's really playing into this is that there has been uncertainty with all the regulation change in the operating models of businesses and how that applies to feasibilities to build things and therefore to justify growth in these sectors. And I'll give an example of how this can manifest and what may happen in days to come, is that I was, for my sins, I was originally with Australian Unity and started the home care business there with a couple of people. And about the fourth or fifth transaction, we bought Home Care New South Wales. And that was just before HCP and NDIS came into the market. Home Care New South Wales had about 10,000 disability clients within their mix. And before we bought them, we did the business case saying, well, we're pretty sure that the funding that's being applied to disability services today will basically marry through into when NDIS gets launched. Surely the price can't drop. God, were we wrong. It went from about $61 an hour for a basic service to about $41. So it wiped out 30% of the business case just after we bought the company. And it really made it difficult from the get-go. So I think what's a little bit worrying to me, I suppose, is that the same people who introduced the NDIS program are now introducing a supported home program. They have learnt from that. I have spoken to some of them, and they have learnt from that experience about how price controls can really impact an industry and actually generate a negative response across the whole sector, and that's where the NDIS has ended up today. Because it does mean that operators have to think about new ways to actually get the same funding that justifies a business model, and it can get a bit messy. But the other part to this is not just supply side, but because we heard from Cam Mansell yesterday that how much no matter what we do on the supply side, we're probably never going to catch up to the demand that's coming down. So the other answer to that problem is productivity improvements. And that's either through workforce and technology, and the combination of both is where it's going to happen. And the convergence of different care models across the whole sector. That really is about removing waste from the whole health system. And by waste, I mean admin tasks that should be done by different people, or potentially by AI and robots in future, or by other mechanisms to really cut down on the amount of time that it takes to get to do the job that we need to do. Connected to all that, of course, has been just the amount of regulatory change that's happened over the last few years has been quite significant. It's not the first time the whole sector's gone through a big shift like this. You know, the introduction of ACFI and living longer, living better was equally as traumatic for those who remember. But what's interesting is a lot of the reform is actually happening in quite distinct silos. But what we're now starting to see is that a change in one particular legislation is impacting others. You know, the liquidity is a good example of that. But I also recall, and Tony will recall this, last year we had obviously the retirement villages word showed up in a draft Aged Care Act for the first time. And it caused quite a lot of consternation with operators around the sector. And we actually went and spoke to, with Dan Gannon, we actually went and spoke to the Health Minister about, you know, what's the meaning of this, and to the department people who actually wrote the legislation, not just the ministers. You know, what do you mean by this word in here? And he said, well, all we're doing is responding to what we're seeing in the sector, which is more care is happening within retirement villages, and we just want to be able to help that and foster that growth over time. It wasn't a Machiavellian, we're trying to here to punish you. It was all about, we're just seeing this trend happening and we think we can help over time. There was also not a lot about you know, any intention to drive more aged care to RV, nothing like that. They really didn't know. All they were trying to do was foster that connection. Of course, as soon as you do that, another department picks it up and then it applies a liquidity change. So it can manifest in random ways. A lot of the discussion back then was around the convergence, that last blue box, of the RV state acts and the federal acts, and how they are starting to interplay more and more. And as the healthcare system and the aged care system interacts with the state-based property sector, you're going to see more and more of this. Will there be a convergence at the legislative level? Probably not, but they're going to have to talk more, and they're going to have to, you know, just like the health sector, figure out how the federal funding and the state-based funding comes together to get to the needs we want. The other part that many people may not be as aware of is around the health sector reform and how much is going on in that area. There is you know, a paper being released every week just about, and coming out of the ageing sector and into health. I can just see there's just as much reform going in that place as well. Particularly around, the government just launched a very detailed paper around their digital investment strategy in the health system, and they're spending billions over the next 4 years trying to connect all the health data across the whole sector, so that when you go to any GP, hospital, whatever, the data follows you all the way through. Whether that happens or not, who knows, but that's what they're trying to think about. If that does manifest, it will absolutely impact how everybody in this room works, because they will connect My Aged Care and other systems all the way through, and their data will follow you, that person, all the way. And that should be available to be used, accessed, and you know, for the betterment of customers on the way through. Other changes in the My Medicare reforms that are coming up are quite significant as well. One of those is that patients, all of us, can nominate a single GP as your main GP, and therefore that GP gets access to different types of funding that can be much more focused on proactive case management and care management for you. That has a big impacts. There are models overseas where this works really well, and this is really Australia's first step down that path, and it will absolutely interact with this sector over time. If you're thinking about a GP who has a patient who's in a retirement home or an aged care village, GPs do not have time right now to make out a plan for all of the care needs that person has. So it goes into different parts of the sector. But in future, if they have specific funding to actually do better care planning, more proactive case management, they will be able to do things like create care plans that interact with the home care system, the aged care system, and the health system, and actually direct traffic across the whole network. That's going to be a fundamental shift. GPs won't be doing all that work, they will have oversight, but the key funding will go to multidisciplinary teams, which includes nurses, social workers, and other type of workers, to help wrap the services around the GP to provide access to all these other disparate services. That's all coming, and it's coming pretty quickly. Having said that, operators and stakeholders across the whole sector, and across everything really, are responding. You know, no one, I think, is standing still. And I hear news stories every day of innovations and different ways of working that are really fascinating. And what's interesting is that governments are actually really interested in responding to good ideas. They want to know what people's ideas are across the sector because this is the only way we're going to implement anything. A good example was the Shared Care Initiative, which wasn't just me, it was all the subcommittee of the RLC that was focused on care and support services, and I know Simon, Sarah and Michelle and everybody's here today. But that went from an idea to a draft of a paper, agreement with a government to a funded trial in less than 12 months. And the reason, which is fast, but the reason they were so responsive to that is because the paper dealt with a sector-wide issue. It wasn't just one operator saying, I need X money, please. It was talking about how can we remove waste and improve services across the whole sector that saves money for government, is better for operators and better for customers. And they were willing to respond really quickly. And I think it's a good example. If you can get that story right and those models right, they will respond and do it quickly, which is good. One of the, there was a couple of quips yesterday about everything new is old again, and people, change happens seemingly in 10-year blocks in this sector. And if we think back to when HCP and NDIS came in 10 years ago, that caused a lot of churn in the sector. Most of the home care operators back then were government funded, state run, council led, on CHSP funding only, no HCP, agency models everywhere. And you think 10 years forward from then, how much has changed? It's been quite significant. So there's a lot of turmoil, a lot of consolidation, a lot of change. But other things that, of course, occurred was PE started to get involved because funding started to leave public purse. It became into private hands, and of course, that's when they can access it. We saw single service provider type models enter the market, whereas used to be Meals on Wheels, council run, suddenly Light and Easy is dropping off meals to people's doors straight away. And so little slithers of service models can start to be cut off and delivered by people who are specialists in those particular areas. They're not done by care workers doing more general work. There was lots of innovation in built form, and there always has been, but there was quite an explosion over the last 10 years. Anyone remember all the household model care home discussions from 10 years ago? That sort of, the dementia village that seemed to be on TV every second week. There was lots of thinking and innovation about how different care models can be evolved. The private aged care model, the integrated living, all on one campus. There was quite a lot that's happened, which has added to the conversation. And I think in the other area that's sort of popped up is insurers, so who have a backing of a private funding body, they're not reliant on government or on fee-for-service payers, started to enter the market about, okay, we're funding health services across the whole system. How can we fund other services that actually reduce reliance on hospital admission, avoid hospital costs and other healthcare costs, and do services in a way that's a little bit more patient-focused but also cheaper for the whole system? So there was a lot of change. And then we saw other models like Mabel, which photos up on the wall there, that came in, which is a completely different way of approaching how the gig economy and the healthcare system can work. None of these companies existed 10 years ago, and they've radically changed the whole sector. Australian Unity wasn't in home care at all, and is now the biggest by far. So when you think about what happened then, and you think about the seismic shifts that are coming, what's going to happen? And I think if you think about the convergence of health and home care and how that's coming and ageing, there's a lot of things going on around the world that we can look at. And one of them is in the diagnostic space. IMED is really innovative. They're starting to do things like you can go and get a radiology check or a scan for cancer or whatever. They now have technology where you don't just get scanned for cancer, then have to go to a hospital. They can pinpoint a laser, kill the cells, and you go home cured. That's coming. That's available today. You don't have to go to the hospital or a doctor at all. Those sorts of treatments, those technologies are already available. There's companies overseas like Amazon who just bought One Medical. One Medical is a GP practice which is half digital and half physical. And so instead of having to physically go to a GP to get everything, if you've got a relationship, you can log in online, get a script, get a medical certificate if you're having a day off. You can get all sorts of telehealth care, and they've actually optimised the system so much that 50% of their consults are now done virtually, which is significant. That does not happen in Australia today. And how hard is it for everybody to get an appointment with their doctor? If you're sick today, you're lucky to get in next week. So those things have to change as we go. Cree is another model that's based in Sweden. It was interesting talking about the convergence of technology and investment in tech that's required. Cree is a business that also does virtual and hybrid GP model that's in 4 countries now. They went from 0 to 30% share of the GP market in Sweden in 10 years. but they've invested $600 billion in doing that. So the amount of money that's been invested in new tech platforms for these sorts of companies is significant. They've gone to 4 countries. There's no reason why, with that sort of model, they can't go everywhere else as well. So the health platforms that we think of as, that's just Google, it's just Amazon, they do TV, they deliver my boxes. They are getting into healthcare. They are getting into the services that will come to your home. And they've got the money, the investment, the time, the skill to think about it in radically different ways. Pharmacy is another area that's a lot of innovation's happening. So everyone with an asset or a building that's got a suite is trying to get people into those stores so they can provide services for them and then buy stuff. So Wes Farmers and Woolies are owning, they've got chemists now as well. They want to add to their retail mix, and health retail is what their angle is. How can they get people into their shops to buy stuff? And the way they're doing that is by being able to provide services while they're there. So vaccinations are very simple. They're starting to hire nurses that can do diagnostics. You walk into Chemist Warehouse, they've got a stethoscope and a heart monitor on the wall. You can just do it virtually and they'll talk to you. All these things are happening, but they're using their retail footprint to deliver health services. And that will continue. I've already heard trials of taking that mobile and starting to bring those sorts of diagnostic tools out into the community, but using it in a retail mindset. They have access to customers, they've got access to capital. They are looking at this, I can guarantee. So really what I just wanted to sort of highlight is that, and someone mentioned it yesterday, the change comes from the fringes. There are players out there that are looking at this sector, the health sector in general, and as these two converge, we'll start to see new players into the market potentially. Bev introduced the Amplar sort of model slide yesterday, and so I won't repeat that, but I just want to focus more on the general practice part of this continuum and where that's sort of evolving to, and which I alluded to a bit earlier. GPs, as we know, are the gateway to the whole health system in Australia. You can't really do anything in a health system without approval or sign-off or referral from a GP. And that makes the system a little bit sticky. It's a little bit inefficient. It's hard to get those. It takes time. You've got to go to a physical location and get in. And the government knows that's inefficient. Just like there are workforce shortages in the ageing sector, GPs are also in dire straits. It's very hard to get GPs. So the only way to solve the lack of supply of workforce in GPs is to think about productivity savings and how can we empower GPs to do more of the high-value work and less the low-value work. Most GPs that I talk to fill a lot of ACAT forms out for patients. So they're spending time after a 4-year degree, 45 minutes to fill out forms for the elderly to get a home care package. It's not the best use of their time. So they're already interacting with this sector, but there's better ways to do that. One of those ways is what's starting to evolve now is proactive case management, and there's a lot of thinking and investment about this, that how can, and there is particular funding in MBS for this, how can GPs create care plans, particularly for those who have chronic disease or long-term issues. How can they create a holistic health plan that includes working with specialists, doctors, hospitals, but also in the community services sector as well. So the services can come to their home to help with management of that disease, whether it's medication management or whatever. But also one of the big pieces that we're starting to see is the integration of social workers into that mix. And the social worker role is very limited in Australia right now, but is much more prevalent in overseas models. And they're really the people that help connect patients and navigate through the whole health system about all the different funding sources that are available to those patients to help them manage their disease. And that includes the age sector as well. So at Amplar, we're running a trial out in Western Sydney at the moment, which is called the Proactive Care Management Trial. Invested $3 million in 3 clinics to trial what a multidisciplinary team, how that can work to support a GP in actually actively managing proactively patients' health outcomes. It's a multi-year plan, and it's already highlighting just how critical some of these social work and nurse practitioners can be in helping the GP do better work with their patients over time. So where could this go? And particularly connected to this sector, as we forecast forward with case management being slightly or almost completely removed out of the supported home funding structure and moving more to a fee for service. We may see models where if the GP is supported through this funding, that they do more of that case management and care planning that incorporates a home care operator as part of the overall health mix, because they will have the funding and the team to do so. So we might see a slight shift or connection into these two systems about how that moves forward. If there is no funding in the home care, supported home landscape to do it, it's not going to happen, but it will get picked up in other places around the health system. Whether that's a coordinated effort or not from the government, I'm not sure, but I think it's a manifestation of what's already starting to happen. So finally, what does this mean? I think, obviously, a lot of the change that's coming will be a challenge, but it's also an opportunity. I'm with Chris. I think we should be optimistic about everything that's coming and think about it in that way. But for patients and customers, this changes will be more about them paying more, frankly, for services. And they will be asked to adapt and change the way that they access those services and moving more away from that sort of physical interaction only model to a more hybrid, digital connected model. It's already happening, but I think it'll expand pretty rapidly. When you think about overseas countries that are already doing 50% of healthcare consults virtually, that's the sort of future we can look forward to in Australia as well. On the policymaker side, I think the big change here really is the move from siloed policy change into a more holistic and connected wider health system. There is a reason why aged care reports into the health department, what we've seen in the last couple of years is that the Department of Premier and Cabinet is usually the place where policy advisors will start to connect all the different departments into one policy change, and they are doing that. And I haven't seen anything out of it yet, but they are starting to think more holistically out of that convergence across all the different ones. They will respond to new ideas, but they will respond to ones that solve sector-wide problems, not just individual company ones, which is why it's so critical that as a sector we work with the peak bodies, the RLC and Ageing Australia, to really drive those agendas forward. They have very strong connections. Dan's done a brilliant job over the last couple of years to build really tight, solid relationships with a federal ageing minister that in theory has nothing to do with state-based RV law, but he's really aware of the sector now, and it's making a big difference, I think. And it makes it able for Dan and Tony to pick up the phone with liquidity issues and things like that and say, hey, let's have a conversation. If you don't have those long-term relationships built, it makes it very hard. So I think that's been a great step forward. On the funding side, we are going to see a mix of private and public funders increase. It's not going the other way, that's for sure. But there will be access to new different types of funding, whether it's PHI or other groups of funding that will start to pay for the health system all the way through, that will start to converge. The technology side, it will be critical. There's presentations about that yesterday, but if you talk about the sector-wide, where it's sort of heading towards is that there will have to be sector-wide platforms where people can interact with, the really smart operators will be able to connect with multiple systems in a interoperable way, so that you don't have to build everything yourselves, you don't have to do everything yourself, but you can work with other providers and other operators and still find a way to share the data all the way through the system to enable those services come forward. Obviously, there's a lot of work going in AI. There hasn't been much discussion about the change in AI right now across the sector, but that's coming rapidly and it's coming very, very quickly. One example, most people probably saw a study last year where they pitted a particular AI that they trained to diagnose cancer against 100 oncologists, like trained doctors. The doctors found the cancer 66% of the time. The AI tool found it 95% of the time. So if you think about that, how that applies to diagnosis and what these tools can do, it's going to be revolutionary. It's going to be virtual. You can access it from anywhere. And with the iMed example, you can treat it not in a hospital. It's all coming. So I think, so obviously, how do operators interact with that? It's really about getting your systems ready to interact with the wider health system. And I think that will, the people that can do that will absolutely stand out amongst the others. In terms of workforce, all the above drives productivity, and that's really the only way that we can see a way through the workforce challenges that we have. We can't grow more people. There's only so many we can bring from overseas. We can't manifest more GPs on a daily basis. So the only way to really optimise what we have is to increase the productivity of the workforce we have. The best way to do that is to empower people to work at the top of scope of practice. So take away administrative and boring tasks from people who shouldn't be doing that and let them work at their top of practice. We talked about nurses doing forms in aged care and doctors doing forms for aged care. That's got to stop, and people need to really focus on, well, we find ways to focus on allowing them to work at top of scope of practice. I'm out of time, but just quickly on existing providers, I think aged care, there'll be a lot of consolidation for a while now, which will limit investment in new aged care development. But that'll come around full circle, and there's already building starting to happen again in that. In the home care sector, there is turmoil coming. The pricing will be the biggest one to keep an eye on. Everybody knows that. Hopefully it's not a repeat of the NDIS, but with the convergence of the health and home systems, I think that players who can navigate through that whole spectrum will be the winners. And on the RV side, I said it yesterday, but we will have to deal with, as a sector, care in the homes. Don't have to do the care. Other people can provide that. But it will be demanded more and more from customers, and it will be a service that needs to be included in the full mix. And obviously on the new entrants, the only thing we can say is let's wait and see who the new entrants will be, because they will come from left field, we won't expect it, and it'll be someone strange. Anyway, thanks very much, appreciate it, and have a good day.
Captain, that was excellent, thank you very much. One question that I have, we're trying to keep on the time, but how long before we get to that situation where this, working just in silos breaks down and we have an integrated system? Are we talking 2, 4, 6 years?
Look, I think we'll see some material shifts within 5 years, but a lot of it depends on the data layer and the interconnectivity of the information. Like if information follows a patient, then that empowers convergence of all that, I believe.
And the lack of GPs, particularly in regional areas, how long will it be before virtual health will take the pressure off those GPs, do you reckon?
Well, there's already companies that do that. In fact, Shane was talking about one that he's invested in yesterday that has a virtual GP model that is connected to hybrid. What we're noticing is that, and this is worldwide, virtual-only GP and health models seem to not work very well. You need that connection to a physical GP as well. So it's the combination that works, and I think it's going to be difficult in rural remote, but having that connection to a person who can actually can talk to face is the models that are going to work.
So you still need a local presence.
You do, yeah. But local in rural sense could be 200 kilometres away. That's okay. When I was running home care and we had virtual services in the middle of nowhere, physical services in the middle of nowhere, you still find ways to get people into those places, but it's just a little bit more sporadic and cost more. But there are ways. Yep. That's all coming.
Okay, so it's an exciting future. Can we show our appreciation? Thank you.